Hello, this is Mario Montoya. I'm an assistant professor at the University of Pittsburgh Medical Center, Department of Anesthesiology, and today I will be discussing basic topics in anesthesiology and anatomy. I have nothing to disclose. In discussing our basic anatomy, I will begin with the neck. In covering the neck anatomy, I will be discussing and reviewing the cricothyroid membrane, internal and external jugular veins, the carotid and vertebral arteries, the stellate ganglion, the cervical spine, bony landmarks, including the vertebral prominence and Chassagne-X tubercle. Beginning with the cricothyroid membrane. The cricothyroid membrane or ligament consists of a central triangular portion known as the conus elasticus and two lateral portions. The conus elasticus connects the thyroid and cricoid cartilages. It is found subcutaneously in the midline and is often crossed horizontally in its upper third by the superior cricothyroid vessels. As seen in the image, you can note the cricothyroid membrane between the thyroid cartilage and cricoid cartilage. The cricothyroid membrane. The two lateral portions are thinner and extend from the superior border of the cricoid cartilage to the inferior margin of the true vocal cords. On either side lie the cricothyroid muscles. The vocal cords usually lie a centimeter above the cricothyroid space. The cricothyroid membrane is of particular interest to the anesthesiologist as an approach to transtracheal catheter ventilation, percutaneous cricothyrotomy, and surgical cricothyrotomy. As seen in this image, next we will be discussing the external jugular vein. At the level of the neck, it runs perpendicularly across the neck. It begins at the angle of the mandible and ends at the middle of the clavicle after crossing the sternocleidomastoid muscle. As shown in this image, the external jugular vein may be seen running perpendicularly from the angle of the mandible to the mid-clavicle. It is usually visible, and Trendelenburg position and Valsalva may further assist in improving visibility. It is safe for patients who are cannulation is safe in patients who are anticoagulated or coagulopathic. Next, we will be discussing the anatomy of the internal jugular vein. The internal jugular vein runs down the side of the neck, usually lying outside or just lateral to the internal carotid artery, and then the outer side of the common carotid artery. At the root of the neck, the internal jugular vein unites with the subclavian vein. An important set of landmarks for the cannulation of the internal jugular vein is the triangle formed by the sternal and clavicular heads of the sternocleidomastoid muscle and the clavicle. In this illustration, you can see the internal jugular vein and its relationship to that triangle, with the vein being deep to the sternocleidomastoid. Here you can see the sternal head, and here is where the clavicular head would insert. When performing central venous catheterization of the internal jugular vein, you would first turn the patient's head so that it is facing the side opposite the site of insertion. The path of the internal jugular vein may be determined using a line connecting the mastoid process and the medial insertion of the sternocleidomastoid on the clavicle. The insertion site of the needle is at the angle created by the two heads of the sternocleidomastoid, and the needle is advanced towards the ipsilateral nipple. If insertion is performed higher in the neck, the carotid artery may lie anterior to the internal jugular vein and may be inadvertently punctured. If the needle is inserted too low in the neck, one may encounter the cupula of the lung and potentially cause a pneumothorax. When performing central venous catheterization of the internal jugular vein, the carotid artery should be palpated and kept medial to insertion site. Following skin puncture, needle tip is directed towards the ipsilateral needle at 45-degree angle with the skin. Complications of central venous cannulation of the internal jugular vein include the potential for arterial puncture, pneumothorax, hemothorax, arrhythmias, malposition, air embolism, chylothorax, infection, and perforation of the internal jugular vein, which may lead to hemothorax, hemomediastinum, or hemopericardium. Next, we will review the anatomy of the carotid arteries. The right common carotid artery originates from the brachiocephalic trunk, also known as the innominate artery. The left common carotid artery originates from the aortic arch. In the neck, the left and right common carotid arteries resemble each other closely. In this image, we may see the common carotid artery as it ascends in the neck and divides into the internal and external carotid arteries at the level of the laryngeal cartilage. The common carotid arteries resemble each other closely as they ascend into the neck. They ascend obliquely cephalad and divide into the internal and external carotid arteries at the superior border of the laryngeal cartilage. They are found internal to the internal jugular vein. The stellate ganglion, we will now discuss the anatomy of the stellate ganglion. The stellate ganglion is composed of the C7 and T1 sympathetic ganglia and provides sympathetic innervation of the face and upper extremity. The stellate ganglion blockade is indicated for diagnosis and treatment of sympathetically mediated pain of the face, neck, and upper extremity. The stellate ganglion is found anterior to the C7 and T1 transverse processes and lateral to the trachea and esophagus. It is anteromedial to the vertebral artery and medial to the common carotid artery. The C6 transverse process, also known as Chassagnac's tubercle, is palpated lateral to the cricoid cartilage, which is where the block is performed. Next, in discussing neck anatomy, we will review the importance of the vertebra prominens. The vertebra prominens is the spinous process of the C7 vertebra. It is an important landmark for determining the midline and level of the spine prior to performing epidural and paravertebral blocks. Next, we will move on to the chest anatomy, in particular the topical anatomy of the chest. We will begin by discussing the topical anatomy of the lungs. Anteriorly, the apex of each lung is blunt and rise between 2 centimeters to 4 centimeters above the medial third of the clavicle. The base of the lung crosses the 6th rib at the mid-clavicular line and the 8th rib at the mid-axillary line. Posteriorly, the lower border of the lung lies at the level of the T10 spinous process and descends further with inspiration. The right lung is divided into three lobes, the upper, middle, and lower lobes. The left lung is divided into two lobes, the upper and lower. Both lungs are divided about in half by an oblique fissure. This may be approximated by a line that runs obliquely from the T3 spinous process to the sixth rib at the midclavicular line. The topical anatomy of the lungs as discussed are important to the anesthesiologist for auscultation as well as for invasive procedures such as central venous access, nerve blocks such as the supraclavicular, infraclavicular, and paravertebral nerve blocks. Continuing with the topical chest anatomy, we will now review the cardiac surface landmarks. Most of the anterior cardiac surface is made up of the right ventricle. It is found posterior and left of the sternum. The left ventricle forms the lateral margin of the anterior cardiac surface and produces the apical impulse 7 to 9 centimeters from the midsternal line at the fifth interspace. The right atrium makes up the right border of the anterior cardiac surface. The left atrium is found posteriorly. Continuing with the surface anatomy of the heart, we will review the auscultatory landmarks. The mitral valve is best heard at the apex of the heart at the fifth interspace, 7 to 9 centimeters from the midsternal line. The tricuspid valve should be auscultated at the left lower sternal border. The pulmonic valve at the second and third interspaces close to the sternum, and finally the aortic valve at the right second interspace close to the sternum. The next subject we will cover under the topic of chest anatomy is the subclavian vein. The subclavian vein is a continuation of the axillary vein as it passes over the first rib. It then converges with the internal jugular vein at the thoracic inlet to form the brachiocephalic vein. It is found deep to the clavicle through most of its course, and the apical pleura is found approximately 5 centimeters deep to the vein at its origin. The vein is a common site for central venous cannulation. The average distance from puncture sites to the right atrium are 14.5 centimeters for right-sided cannulations and 18.5 for left-sided cannulations. Potential complications include air embolism, arterial puncture, arrhythmias, pneumo or hydrothorax, cardiac tamponade or pericardial effusion, or hydromediastinum. The next subject we will cover are the vertebral topographical landmarks. These landmarks are important for determining the appropriate level at which to perform procedures such as epidural, paravertebral, and lumbar plexus blocks. The most cephalad landmark is the vertebra prominens, which is the C7 spinous process, named so because it is the largest and therefore most prominent of the spinous processes. The root of the scapular spine corresponds with the T3 level of the spine. The inferior angle of the scapula is at the level of T7, and the intercristal line, or the line between the two iliac crests, is at the level of L3, L4. Next, we will review the caudal space. The sacral hiatus is formed due to failure of fusion of the fifth sacral vertebral arches. Remnants of the arch feature two prominences, the sacral cornu on either side of the hiatus. The sacral hiatus extends from the sacral cornu to the fourth sacral vertebrae. The sacrococcygeal membrane covers the sacral hiatus. The caudal space contains the cauda equina, blood vessels, lymphatics, fat, and connective tissue. It is at this space that caudal blocks may be performed. They are usually performed in pediatric patients as the overlying ligaments have not yet ossified. Next, we will cover the basic anatomy of the extremities. Beginning with the upper extremities, we will first review the bones of the upper extremity. The bones of the upper extremity consist of the humerus, radius, ulna, 8 carpal bones, 5 metacarpal bones, 5 proximal phalanges, 5 middle phalanges, and 5 distal phalanges. The image found on this slide illustrates these bones and their anatomic relationship. Next, we will discuss the blood vessels of the upper extremities. The arterial supply is provided by the axillary artery, which is a continuation of the subclavian artery. It begins at the outer border of the first rib and extends at the tendon of the teres major muscle. It continues as the brachial artery, which is found medial to and eventually passes anterior to the humerus. Distal to the antecubital fossa, the brachial artery divides into the radial and ulnar arteries. The radial and ulnar arteries travel to the lateral and medial aspects of the wrist, respectively, where they usually provide collateral arterial blood supply to the hand. Moving on to the veins of the upper extremity, we find the most proximal veins to be the cephalic and basilic veins, as shown on the illustration. At the cubital fossa, the median and cubital vein are found more distally. At the cubital fossa, the median cubital vein is found, and more distally, the dorsal venous network. Now we will discuss the nerves of the upper extremity. The brachial plexus and its branches provide most of the innervation of the upper extremity. The brachial plexus is comprised of the ventral rami of the C5 through T1 nerve roots. These roots then coalesce to form the superior, middle, and inferior trunks, divide to form 3 anterior and 3 posterior divisions, and then coalesce to form the lateral, medial, and posterior cords. The terminal branches of the brachial plexus include the musculocutaneous nerve, which contains contributions from C5, 6, and 7, the axillary nerve, whose contributions are C5 and 6, the radial nerve, which is derived from C5, 6, and 7, the median nerve, which contains contributions from C5, 6, 7, 8, and T1, and finally the ulnar nerve, which is derived from C7, 8, and T1. Moving on to the lower extremity, we will begin by reviewing the bones. These include the femur, found in the thigh, the patella, the tibia and fibula, which are found in the leg, and the bones of the ankle and foot, which include the calcaneus, navicular, and cuboid bones, the talus, cuneiform bones, and the metatarsals and phalanges. As shown in this image, you can see their anatomic relationships to each other. Next are the blood vessels of the lower extremity. The arterial blood vessel, main arterial blood vessel of the lower extremity is the femoral artery, which is a continuation of the external iliac artery. Its major branches include the deep artery of the thigh, genicular artery. Its major branches include the deep artery of the thigh and genicular artery. It becomes the popliteal artery and the popliteal fossa. the popliteal artery divides into the anterior and posterior tibial arteries. The anterior tibial artery progresses to become the dorsalis pedis artery. Next are the veins of the lower extremity. The major vein of the lower extremity is the femoral vein, which further divides into the great saphenous vein and eventually the dorsal venous arch. These are of importance to the anesthesiologist, as venous access of the upper extremities may be difficult, and sometimes one must obtain access in the foot or ankle. Moving on to the nerves of the lower extremity. There are two major plexuses that provide sensory innervation to sensory and motor innervation to the lower extremity. First is the lumbar plexus, which is composed of the ventral rami of the spinal nerves T12 through L5. These coalesce to form anterior and posterior divisions. The anterior division forms the lateral cutaneous nerve of the thigh and the femoral nerve. The posterior division forms the obturator nerve. The femoral nerve enters the thigh posterior to the inguinal ligament and deep to the fascia iliaca. At this level, it is immediately lateral and slightly posterior to the femoral artery. It divides into anterior and posterior branches. The posterior branches innervate the quadriceps muscle and knee joint and give off the saphenous nerve. The lateral cutaneous nerve of the thigh enters the thigh slightly medial to the anterior superior iliac spine. It provides sensory innervation to the lateral aspect of the thigh. The obturator nerve enters the thigh through the obturator foramen on the medial thigh and divides into anterior and posterior branches and provides sensation to the medial aspect of the thigh. Continuing with lower extremity innervation, we move on to the sacral plexus. The sacral plexus is formed by the L4 through S3 nerve roots. These eventually coalesce to form the sciatic nerve and the posterior cutaneous nerve of the thigh. The sciatic nerve is the largest nerve in the body. It exits the pelvis through the sciatic notch deep to the piriformis muscle and descends between the greater trochanter of the femur and the ischial tuberosity. It descends along the posterior thigh to the lower third of the femur and then divides into the tibial and common peroneal nerves. These nerves are found superficial to the popliteal artery at the level of the popliteal fossa. The common peroneal nerve descends along the head and neck of the fibula. Terminal branches are the superficial and deep peroneal nerves. The tibial nerve continues its path vertically through the popliteal fossa and eventually posterior to the medial malleolus. It has a collateral branch, which is the sural nerve, and terminal branches, which are the plantar nerves. Next, we will be discussing radiological anatomy. Much of this anatomy is going to be reviewed and labeled in the form of the slides provided. Beginning with the chest x-ray, important structures to note are the trachea, which allows us to determine the level of endotracheal tubes, the anterior and posterior ribs, the heart, which includes the right atrium, and the left ventricle, and of course the lung fields, as well as the diaphragm, shown here. More cephalad, you can see the clavicle and the bronchial bifurcation. Moving along to the CT of the chest, as labeled and provided on the key, you can appreciate the aorta, the left superior lobe of the lung and right superior lobe of the lung, the azygos vein, moving further down in the thorax, you can see the right and left bronchus, aorta and pulmonary arteries, and moving further along, you can see the upper lobe of the liver, right and left ventricles, and inferior vena cava. Next is the MRI of the chest, which shows a clearer picture of the soft tissues of the thorax. At this level, you can appreciate the aorta, pulmonary veins, superior vena cava, again the descending aorta, and the pulmonary valve. Next, we will be reviewing images of the CT of the brain, showing the brain at various levels. And you may appreciate the right and left hemispheres readily on these images. Next is the MRI of the brain, which again allows one to visualize the soft tissues more easily. And on this image you can appreciate the frontal lobe, thalamus, corpus callosum, pons, cerebellum, and spinal cord. Next we will review the the X-ray of the cervical spine. And here on this image you can see the lateral and anterior cervical spine X-rays. On the lateral X-ray, the spinous processes are noted posteriorly, the facet joints and vertebral bodies more anteriorly. On the anterior X-ray, the trachea, vertebral bodies, and intervertebral discs are visible. The upper cervical spine X-ray allows visualization of the odontoid process in the zygapophyseal joint space. Next is the cervical spine CT scan, which allows one to visualize the vertebral bodies, intervertebral discs more readily, as well as the spinous processes and the spinal canal, making this a good imaging process for injuries to the spine, cervical spine. The cervical spine MRI, as shown on this slide, allows one to visualize the soft tissues more easily. This is labeled extensively, and you may note the spinal cord itself, the posterior longitudinal ligament, cerebral spinal fluid, and the various spinous processes, vertebral bodies, and intervertebral discs. The thoracic spine X-ray shows the trachea, ribs, spinous, and transverse processes. The lateral thoracic spine X-ray shows the thoracic vertebral body and intervertebral disc. The CT of the thoracic spine allows one to more clearly see the vertebral bodies, spinous and transverse processes, and the vertebral foramen. Again, the MRI of the thoracic spine allows one to better visualize the soft as well as bony structures of the spine. As highlighted in this image, structures such as the intervertebral discs, spinal cord, and nerve roots are readily visible and identified. Next, we will review the ultrasound anatomy of the internal jugular vein at the level of the neck. The internal jugular vein is deep to the sternocleidomastoid muscle and lateral to the carotid artery. When visualized on ultrasound, it is compressible and usually non-pulsatile. You can appreciate its proximity to the carotid artery, and care must be given when cannulating even under ultrasound guidance. This image shows a CT of the neck and labels multiple structures, including the cervical spine, epiglottis, pharynx, vallecula, hyoid bone, and the vessels of the neck. We will now discuss some of the anatomy we have covered as it applies clinically. Beginning with upper extremity bones, fractures of the humerus may lead to nerve injury as well. In particular, fractures of the humeral neck may injure the axillary nerve. Fractures of the shaft near the radial groove may lead to injuries of the radial nerve. A fracture of the distal humerus may lead to median nerve injury, and the medial epicondyle fracture may be associated with ulnar nerve injury. Patients with fractures of the humerus should be evaluated for neurologic deficits, and these deficits should be documented prior to implementing any regional anesthetic techniques. Next, we will review upper extremity arteries and their clinical applications. Multiple sites are available for invasive blood pressure monitoring. We will review each of these and their benefits and disadvantages. The radial artery is the most commonly used for cannulation. It is superficial and usually has good collateral blood flow. A modified Allen test can be performed prior to cannulation to ensure adequate circulation. The brachial artery is a large artery, easy to identify. However, it is an end artery without collateral flow, and should it be occluded, develop a hematoma or a thrombosis, may lead to ischemia of the distal extremity. The axillary artery is also a large artery. However, the proximity of several nerves make it high risk for nerve injury. There's also the potential for emboli to the brain. The ulnar nerve is deep and tortuous and should not be used if repeated attempts at cannulation of the radial artery have been attempted, as this may interrupt collateral flow to the hand. Next, we will discuss upper extremity innervation. Regional anesthesia for the upper extremity is performed with neuroblockade of the brachial plexus. Nerve blocks may be performed anywhere along its course depending on your goals for analgesia. This slide illustrates the various approaches to blockade of the brachial plexus. Also noted are areas of sparing for the various approaches. As you can see, at the root level, you will have excellent analgesia of the shoulder, proximal humerus, and most of the arm, with the exception being the ulnar distribution, which you would expect to have sparing. The supraclavicular block, which is performed at the level of the trunks, will provide excellent analgesia from the mid-humerus to the hand. The infraclavicular block, which is performed at the cord level of the brachial plexus, will also provide excellent analgesia from approximately the mid-humerus to the hand. The axillary block, performed at the terminal branches of the brachial plexus, will provide excellent analgesia of the distal humerus and the hand. It's notable that the musculocutaneous nerve has already started to separate from the other terminal branches and needs to be blocked separately in order to get appropriate analgesia of the lateral forearm, as it has a branch, the lateral cutaneous nerve of the forearm. This slide illustrates the sensory innervation of the branches of the brachial plexus. As shown, the cutaneous, muscular, and bony sensation do not always overlap. In general, the axillary nerve covers the deltoid. The ulnar nerve provides sensation to the small finger and medial portion of the hand. The musculocutaneous nerve provides sensory and motor innervation to the biceps and has a sensory branch which provides sensation to the lateral forearm. This branch is known as the lateral cutaneous nerve of the forearm. The radial nerve provides sensation to the extensor surface of the arm and hand, and the median nerve, the medial forearm and ventral portion of the thumb, first and second fingers, and half of the ring finger. Continue with clinical anatomy, we will discuss the lower extremity bones. Bony landmarks of the lower extremity are helpful for performing blocks in regional anesthesia. The anterior superior iliac spine is the landmark for the lateral cutaneous nerve of the forearm. It is palpated and a mark is made 1 centimeter lateral and 1 centimeter inferior to the anterior superior iliac spine, and this is where the block is performed. The greater trochanter and ischial tuberosity provide the major landmarks for providing a subgluteal approach to a sciatic nerve block. The medial and lateral malleoli provide bony landmarks for performing ankle blocks. Moving on to lower extremity vascular and its clinical application. The femoral artery is found lateral to the femoral vein at the level of the inguinal ligament. The femoral nerve is just lateral and slightly posterior to the femoral artery. The femoral artery is a landmark for arterial and central venous access, as well as for femoral nerve blocks. Ultrasound guidance may facilitate performance of these procedures. This ultrasound image shows the relationship of the femoral nerve, artery, and vein in the inguinal region, with the nerve being the most lateral structure. So on the slide you can see the nerve, the circular and non-compressible femoral artery, and then the femoral vein being the most medial structure. Next, we will discuss innervation of the lower extremity and its applications. The lumbar plexus is the lumbar plexus eventually forms the femoral nerve, lateral femoral cutaneous nerve, and obturator nerves. These nerves provide sensation to the anterior thigh, medial leg, lateral thigh, and medial thigh respectively. A lumbar plexus block may cover all three nerve distributions. You may also block each nerve individually depending on your analgesic requirements. With regards to innervation of the lower extremity, the sacral plexus, the sciatic nerve, superior gluteal nerve, and posterior femoral cutaneous nerve provide sensation to the lower leg and the posterior thigh. The sciatic nerve provides complete motor innervation below the knee, with the exception of a sensory an area of sensory innervation provided by the saphenous nerve. This sensory this area of sensory innervation is found on the inner portion of the lower leg. This image provides further visualization of the innervation of each of these nerves, with the femoral nerve providing sensation to the anterior thigh, the lateral femoral cutaneous to the lateral thigh, the obturator to the inner thigh, and the saphenous, which is a branch of the femoral nerve, providing sensation to the medial portion of the leg, and the sciatic nerve providing sensation to the leg, with the exception of the saphenous distribution. You can also see the nerve to the hamstring muscle providing some sensation to the musculature, and the posterior cutaneous nerve providing cutaneous innervation, sensory innervation to the posterior thigh.